Hi, everyone who just joined us. We're just going to wait a few seconds and let everyone come in from the waiting room, and then we're going to get started. I'm Judy Krasna. I'm the Executive Director of F.E.A.S.T. Welcome to today's webinar, and thank you to our presenters. We're just going to start with a few housekeeping rules. Please stay muted and keep your camera off during the entire webinar. And if you have questions during the webinar, you can just use the chat box. And we'll have a Q&A session at the end, and hopefully we'll get to all your questions. And now let's move on to the topic of our webinar, Understanding ARFID and its Genetic and Environmental Causes. Welcome, Dr. Nadia Micali and Dr. Lisa Dinkler. I'm going to let today's speakers introduce themselves. We're honored to have you both with us today. Thank you so much for presenting.
Thank you very much for having us. We're really delighted to be here today. And as the participants know, we will be talking about understanding ARFID and its genetic and environmental causes. And Lisa Dinkler and I will be sharing this presentation. It will be a bit of an exercise in cognitive flexibility because we will be sharing the slides and sharing the presentation. So we'll start by introducing ourselves. I am Nadia Micali. I'm a child psychiatrist by training, and I am currently the head of research in eating disorders at the Psychiatric Center in Ballerup in Denmark. And I have quite a long experience in working with individuals with ARFID across the age range. I've been working with children and adolescents with ARFID since about 2011. At the time, it wasn't even called ARFID, but children with feeding difficulties. And over the years, I've been doing clinical work with individuals with ARFID, but also research in ARFID since about 2018. Lisa?
Great, thanks, Nadia. Yes, I am a postdoctoral researcher at the Center for Eating Disorders Innovation at Karolinska Institutet in Sweden, in Stockholm. And I have been doing ARFID research for a couple of years now. I started out doing research on anorexia nervosa and autism and how they relate together. And now I focus fully on ARFID, basically. Yeah. So this is our talk map for today. We will first, yeah, do you want to go? Yeah.
No, go ahead, Lisa.
Yeah, we will first talk about a little bit what ARFID is actually, and then who is affected by ARFID. We will talk about co-occurring conditions concerning mental but also physical health, how we can assess ARFID diagnostically, what is currently used to treat ARFID, and also we have some points about potential causes and risk factors. And then we're coming into why genomic studies are important to improve care for eating disorders. And then we're going to talk about the ARFID genes and environment study that currently is going on in the US. So first of all, we would like to start by getting to know you. So we have a couple of questions for you, and I would like everyone to go to menti.com and type in this code. It's 45330099. And the code will come up again. I need to stop sharing and share another screen. Just give me a second. So we can actually also have the presentation here. Okay, so you can see the code on the top of the slide here also. Oh, and we're already getting in answers. Great. So the question is, what is your experience of ARFID? Can someone maybe tell me how many people we have in the webinar so we know approximately how many could potentially answer?
There are 7 right now.
Oh, yeah. Okay, so I guess yeah, the 5 of us are probably administrating this. So we have here 2 clinicians in the audience who work with ARFID. So we're moving on to the next question. Oh, and one other. Okay. Right. So the next question would be, if you have children with ARFID, how old are they? We have one person with an adult child with ARFID. Okay. I guess there are maybe no more answers coming in, so I will move on. If you're a clinician working with ARFID, how old are your patients? We have one person working with children and adolescents with ARFID. Okay, I think I will move. Okay, and one person working with adults with ARFID. Nice. Next question would be, if you or a loved one have ARFID, have you or they been diagnosed by a healthcare professional? Yes. Okay. One person says yes, one person says no. Okay, great. And then, do you think genetic research is important to improve diagnosis and treatment of eating disorders? Very important. 3 persons think it's very important. That's great. Okay. And the last question would be, what are you hoping to take away from today's webinar? And you can type in your answer here, and they will come up on the screen. Maybe just some short bullet points here. See one answer. Okay. I'm not sure why. Okay, one person has answered. I'm sorry, it's not showing up right now. So I'm just gonna. Okay, we have 3 answers here. We can come back to that. I can check them in the meantime.
I think at the bottom, Lisa, it says press enter to show answers.
Ah, thanks, Nadia. Thanks. Fantastic. I'm looking for more help for my 2 children with ARFID 18 and 19 years. Okay. Assessment and evidence-based treatment recommendations and treatment of ARFID. Okay. Yeah, we will definitely talk a little bit about assessment and treatment. So that's great. All right. So I will stop sharing. Thank you so much for answering our questions. And Nadia, you will go ahead, right?
Well, yes, I will now start sharing. And thank you so much for sharing your experiences and what you wish from today. So let me just go ahead and do this. Okay. So my task is to start with saying a little bit about what ARFID is, and I'm sure the majority of you will know, but it's always nice to know that we are starting from the same perspective. Of course, ARFID came into diagnostic manuals in 2013 in the DSM-5, and the way we define ARFID is saying that ARFID is characterized by a series of feeding difficulties, mostly restriction and avoidance of foods, and it has severe consequences, and it is also defined by some exclusion criteria so that we know that the manifestations of ARFID are not explained by weight and shape concerns, including anorexia nervosa or bulimia nervosa, other eating disorders, and also it occurs but is not explained by lack of food or current cultural practices in the context of the individual's life. And also another important exclusionary criteria is that of co-occurring mental or somatic disorders. And diagnostic manuals are very clear that if there is a co-occurring mental or somatic disorder, then the symptoms that we see in the individual need to go over and above what we would normally see in that mental or physical disorder. Of course, the consequences of the avoidance and restricted eating can be quite severe. In particular, those defined by diagnostic manuals are significant weight loss and, in children and adolescents, failure to gain weight or faltering growth. Nutritional deficiencies can be deficiencies in macro and micronutrients, dependence on enteral feeding or nutritional supplements, exemplified by reliance on oral supplements or enteral or parenteral feeding, and an important criterion, marked interference with sex-social functioning. In diagnostic manuals and in our clinical and everyday experience, we've recognized that there are different clinical presentations. It is yet unclear if these clinical presentations are mutually exclusive, because what we know from our clinical experience is that, in fact, there might be some overlap in presentations. And we are actually almost finishing a research grant with some colleagues in Boston, Jenny Thomas and Liz Lawson, where we will be trying to answer this question of overlapping clinical presentations. So the first clinical presentation that I will describe is that of lack of interest in eating or food, or also low appetite. In this presentation, individuals with ARFID show low levels of hunger and describe relatively poor appetite. And this ARFID presentation is characterized by high arousal, being easily distracted, and a certain difficulty in food intake. And this presentation is probably what used to be called food avoidance emotional disorder or infantile anorexia. And individuals with this presentation will often tell us that they don't feel hungry, that they feel eating is a chore and not something that they look forward to. The second clinical presentation, and I would say, in my clinical experience, the most common one, is avoidance based on the sensory aspects of food. And this particular presentation is characterized by avoidance of foods based on their characteristics. So it can be due to their taste or smell or texture or appearance or even temperature. So not eating foods that are cold or hot. And this presentation is kind of quite similar to extreme selective or picky eating. And it also used to be called, prior to DSM-5, food neophobia. And it is characterized by this need to, or this difficulty in eating foods that are new or that are different from what the individual usually eats. And it can be common to have strong disgust reactions in this presentation. And the one of the things that individuals who have this presentation will tell you is, for example, I don't eat vegetables because they're bitter. And then our third clinical presentation is that linked to concern about aversive consequences of eating. And this presentation is characterized by specific fear of vomiting, choking, or allergic reactions or other discomfort when eating. And it is common, for example, in individuals who have vomit phobia. And in the past, it was also called functional dysphagia, as well as other terms. And it can follow a traumatic event, for example, choking on a certain food, or having experience of kind of vomiting following specific foods. And something that you will hear individuals say with this presentation is, for example, I know I will be sick if I eat. Okay. So how common is ARFID in the general population? Studies have shown that about 1 to 5% of individuals in the general population might have ARFID. Of course, we are still in the infancy of epidemiological research on ARFID, and we need to do a lot more, but this is already a good starting point. We also know that ARFID is present in individuals of all sexes and genders. And it looks like the male-to-female ratio is close to 1-to-1. And there might actually be more males amongst children with ARFID. And then this female-to-male ratio might get equal to 1-to-1 in adulthood. And we know that ARFID, by definition, because the diagnostic category says that we can diagnose ARFID at any age. So we know that ARFID affects individuals at any age, although we know that onset is sometimes more common in childhood. And importantly, we know that ARFID can really manifest in individuals at any body size. It doesn't matter what the size is, but ARFID can be present in any kind of weight or body shape or body size. ARFID is also known to have either an acute onset, sometimes presentations that are characterized by aversive consequences or concern about aversive consequences can have an acute onset, but ARFID can also be a long-standing difficulty. And I've seen many clinical cases in my clinic of individuals who have had ARFID for a long time and have never been able to know what the issue is or why they're having the symptoms that they have. From research studies, we know that ARFID is common at different rates according to the population that we are studying. So, for example, we know that ARFID is very, very common in pediatric feeding clinics, up to 64% amongst children. And it is relatively common in eating disorder treatment programs. About up to a quarter of cases have ARFID. And as we go to more general type of clinical settings, then ARFID becomes slightly less common, but still relatively common, I would say, looking at these figures. So, for example, up to 7% of general pediatric referrals have ARFID. 4% of gynecology patients up to the age of 18 have ARFID, et cetera, et cetera. And you can see that the prevalence of ARFID also clearly depends on the context. It might be more common in some settings, and I will share later on some evidence about the comorbidity and co-occurring disorders in ARFID, and you will see why that might be the case. So there we are talking about co-occurring conditions, and we know that ARFID is certainly comorbid and overlaps in terms of presentation with several psychiatric disorders. And here we've grouped them by color in terms of the type of psychiatric or a psychological disorder. We know that ARFID is or has a strong comorbidity with developmental disorders, for example, autism spectrum disorders, ADHD, intellectual disability, and other developmental disorders. We also know that there is an important comorbidity with depression, and there is also a large percentage of individuals with ARFID who have obsessive compulsive disorder and other anxiety disorders. And of course, particularly individuals with the clinical presentation of concern about aversive consequences are likely to have a comorbidity with anxiety disorders. As I was mentioning before, there is also a strong comorbidity and shared pathophysiology with other medical disorders. And again, here we've grouped them by color in terms of the system, the bodily system that is affected. There is a strong comorbidity and overlap between ARFID and GI, gastrointestinal disorders, as one would expect. And we know that these disorders can be both co-occurring with ARFID, but also might precede the onset of ARFID. And in particular here, we think about reflux disorder, particularly common in newborns and young infants, food allergies, or dysphagia. If we move on to other gastrointestinal tract disorders and going further down our gastrointestinal system. Also, celiac disease, constipation, and inflammatory bowel diseases are comorbid with ARFID. In terms of neurological type disorders, cerebral paresis and cerebral palsy and epilepsy have been shown to occur in ARFID. And looking at other systems, also heart problems, particularly congenital heart malformations, can be comorbid and lead to ARFID, as well as asthma, and that's probably linked to kind of allergic disorders. I think, Lisa, this is now up to you. Am I right? I think you're muted, Lisa.
I'm sorry. Thank you, Nadia. Yes, so we will continue talking about the diagnostic assessment of ARFID. And here we have a couple of interviews that have been developed during the last years. We have 4 of them. The first 3 are more semi-structured, where the interviewer has more flexibility, and the last one is very structured. And I would say that the PICA, ARFID, and rumination disorder interview, or short, the PARDI, is probably the most detailed interview, where we get most information on the reasons why someone has this avoidant restrictive eating. And you can see that these interviews have also different age ranges that they can be used for, and different versions in terms of who is the informant. So it could be the caregiver or the parent, but it could also be the child themselves or the adults themselves. So there are different versions, and they are still being evaluated, and they all have their own disadvantages or advantages, kind of. And then we also have questionnaires. We have screeners that are more to be used in larger populations to look at if there are any ARFID symptoms at all, and that would be the 9-item ARFID screen, the NIAS, or the ARFID brief screen, for example. And then we have a questionnaire called the PARDI ARQ, which has been developed in line with the interview that we just talked about. That is more for clinical population. So it's a longer questionnaire that goes more into depth. And here again, you see the different versions of these questionnaires for parents or caregivers, and also self-reported versions, and for different age ranges. So also these questionnaires are still being validated. There are a lot of studies ongoing currently that use them to see how well they can identify ARFID. And so a couple of words also about treatment approaches. When it comes to treatment and also assessment, actually, it's very important that this is done in a multidisciplinary team, because there are really many aspects to ARFID. It's not only the psychological side that is important, but it's also very important to consider the medical and the nutritional side of it. Because as Nadia has told us previously, we see a lot of comorbidity with medical or somatic disorders, however you want to call it. So this is very important to consider, because they could potentially actually cause the restricted eating and explain the eating behavior in that way. And then you wouldn't diagnose ARFID. But it's also important to consider them in the treatment of ARFID, because they're going to affect the individual. And most importantly, when it comes to the medical side, is of course to monitor weight and growth, and to manage any physical consequences of ARFID, of the restricted food intake. When it comes to the nutrition, it's important that this is monitored by a dietitian who really checks the individual's food intake and sees what micro and macronutrients they are getting. Often it's, of course, also about weight restoration, sometimes with tube feeding or supplement drinks. Sometimes it's also sufficient just to add like a vitamin supplement, for example. So these things need to be reviewed and monitored very carefully. And then when it comes to the psychological treatments, there are currently a lot of approaches that are being used. Most important, I think, is always the psychoeducation about ARFID itself to the child, to the parent or the adult, what ARFID is, what that means, where it might come from, what they can themselves do, all these things. Parent coaching, often in groups, is a very good low-level approach. And then what is currently done is that approaches from other eating disorders and anxiety disorders are being adapted for ARFID. So we have cognitive behavioral therapy, CBT, and family-based therapy, FBT. And I listed some approaches here that basically are part of CBT or more behavioral therapy, such as systematic desensitization, where you slowly get used to foods in a stepwise approach. So, for example, first seeing, like accepting having the food in the room, then having it on the plate, then touching it, and then licking it, and then tasting it. But also learning habits and learning to have a routine and structure around food is very important, especially for the presentation with low interest and lack of appetite. So here it's important, for example, not to wait until you're hungry, but like to eat at a certain time. So to get in this routine. And also exposure therapy can be very important. For example, for the anxiety presentations where you are afraid of getting sick, if you remember this example that Nadia mentioned. Currently, there are no approved pharmacological treatments, but there are some trials ongoing to test medicines that might potentially increase appetite and decrease anxiety, for example. And importantly, there are no national treatment guidelines in the US and in most or all other countries, I'd say. I know that in Sweden, we are currently working at that. Okay, so now I will present some potential causes and risk factors for ARFID. And I really want to emphasize that most of them are so far hypotheses or things that have been found related to feeding difficulties or other eating disorders, but not specifically ARFID. What we do know is that, as Nadia also mentioned earlier, that traumatic events with choking or vomiting or similar experiences can precede the onset of ARFID. And then the onset is often very, very sudden in order to avoid the event happening again, for example, choking. But also, as we've already mentioned a little bit, other disorders can be a risk factor for ARFID. So, for example, when you have gastrointestinal problems and a lot of things going on in your stomach, a lot of pain or sensations that you don't like, you might avoid eating because you want to avoid these sensations. But also the fear of allergic reactions. And in a similar way, autism and ADHD might predispose someone to ARFID because of the likelihood of sensory sensitivities that they bring with them. Also, temperament and personality can be a risk factor for ARFID, especially when it comes to anxious temperament that might be reflected in regulatory problems already in infancy. So that means problem with sleeping, feeding, or crying, for example. But also impulsivity, inattention, hyperactivity can be problematic in terms of focusing on food and having regular meal times. We know from studies on feeding difficulties in general that a family history of anxiety or eating disorders can increase the risk for them. And related to that, we see, although this also hasn't been shown in studies yet, as far as I'm aware, specifically for ARFID, that if parents are very anxious about their child's eating, that this can actually exacerbate the eating difficulties and maintain ARFID. So, but it seems that really the largest contributor to ARFID is a genetic predisposition to it. And that is, of course, related to the other factors we've just talked about, because temperament and personality, they are all genetically influenced. So we recently showed that the heritability of ARFID is around 80% in Swedish twins. And that means that the likelihood whether someone develops ARFID or not is to 80% influenced by their DNA. So this is very interesting because it really places ARFID amongst the most heritable of psychiatric disorders. So other eating disorders such as anorexia nervosa and bulimia nervosa, they have a slightly lower heritability, while, for example, autism and ADHD have a similarly high heritability as ARFID has. And this brings us also to the point why genetic studies are important, because they can really help us to understand the biological causes of eating disorders. And then in turn, this will help us to improve methods for detection, diagnostics, and treatment of eating disorders. And for anorexia, we really have some initial success here with the ongoing genomic studies that have showed us that anorexia nervosa might actually be better understood as a metabopsychiatric disorder. So that means that it has an important metabolic component, and it's not only a psychiatric disorder. And we're trying to catch up for the other eating disorders, for bulimia nervosa, binge eating disorder, and the more atypical or sub-threshold presentations. But we're really lagging behind for ARFID and just starting to collect data. And this is what we're going to talk about in the last part of the presentation.
Thanks, Lisa. I will now share my screen. And I'm really delighted to be able to talk to you about the ARFID-GEN study. We are really pleased that NIMH funded this 2-year grant, which is led by Professor Cynthia Budick and myself. And the reason why we want to share that with you is because, as Lisa was saying, we are very excited about what the genomic discoveries have helped us, how they help us rethink anorexia nervosa. And we think that this might be kind of quite crucial in understanding ARFID. So I will tell you a little bit more about this study. So the goal of ARFID-GEN is to help us understand the genetic and environmental factors that influence risk for ARFID. And it is the first study of genetic and environmental factors influencing ARFID, certainly in the US. And it is certainly the first study in the world to collect genomic data on ARFID. So we are really proud of this study and the fact that NIMH decided to fund this study. We are currently enrolling about 3,000 individuals across the US who have extreme picky or selective eating and ARFID, and an exclusion criteria is that the individuals don't have another eating disorder. So the main presentation and the focus of the eating problems is really ARFID or extreme selective eating. It is, of course, as many studies, those of you that have experience of research, an enormous challenge, because as much as NIMH gave us this wonderful opportunity to carry out this very important study, it also comes with a little burden, which is that we have 2 years only to recruit 3,000 individuals with ARFID who provide all the data and information that we require for the study. So, you know, with kind of excitement comes responsibility as well, as we all know. I want to really highlight that ARFID-GEN was a co-production, and we really thought through the study with individuals with lived experience and parents before planning the study. And we certainly believe in this participatory experience, and we think it is very, very important. And I wanted to share a little bit of what this participatory exercise told us in kind of three sections. So what we heard from people with lived experience or parents is that everyone thought that ARFID is a diagnosis that we need to know more about, and that we need an evidence base that is not there right now. We also heard that the most common experience was that healthcare providers don't really take it seriously, and that there is a need for age-appropriate care, which is not really there yet, and that we need more ARFID-specific treatments. Lisa told us a little bit about current treatments, and there are a few that have been specifically designed with ARFID in mind and that have been adapted to ARFID, but we still have a long way to go. And participants also told us that we need to train dietitians, speech, language, and occupational therapists, and other healthcare providers that are not, the ones that are usually in contact with individuals with eating disorders in particular. Another important theme that was raised is that there is a general need for community and awareness of ARFID, and that we need to help others, and also that we all collectively need to learn more about ARFID. We were also told that there is a lack of a sense of community, and I think F.E.A.S.T plays a great role in helping those individuals or those parents come together and really find the support. But we were told that that is something that is currently lacking in the community, and that we need early support in schools for those children who have ARFID whilst they are developing, and that families really feel that they need guidance on how to support their loved ones with ARFID. Participants also told us that they felt it would be important for children to meet and be exposed to peers who have the same problems. And I know that certainly in some groups that we ran a while ago in my clinic, we found that that was very powerful, that children could actually meet other children who had similar problems and really feel that they weren't singled out and the only ones with ARFID. And the last point relating to this that participants told us is that they felt that we should disseminate the results of our study widely to spread awareness and hope. And we know that those are two elements that are really important to families and individuals with lived experience. And then lastly, the last theme that was kind of brought to our attention during this was research participation, and we had a lot of feedback on our study design, on the fact that it was very important for us to be inclusive, culturally sensitive and positive, and that we also had some playful environments, and we've tried to do so, and I hope it reflects in how we've designed the study. Of course, an important focus of the study is genetics, and our participants told us that they felt that that was very important, but also that we needed to be clear about how data were being stored and purposes of collecting data. And I know that that particular one can be quite a sensitive issue for some participants. One of the concerns that participants thought that we should think about is how children might be embarrassed or may not want to answer questions about food. And again, that is something that we thought through when we designed the study. Our participants really saw the potential of this study, in particular in helping us find answers and see, what the genetic links are to ARFID, and that could really help us understand ARFID more and really change the field going forward. So what does the study entail? The participation is kind of described in this slide. We have some eligibility steps before the participants go into kind of full the full study, and in order to be eligible, individuals need to be aged 7 or plus, and for those that are below the age of 18, we require parent and child participation, as you would expect. An important eligibility criteria is residing in the US, because this is a US-funded study. Of course, we ensure that our participants have ARFID and meet criteria for ARFID, and that they don't have a current eating disorder. We also exclude those individuals that have regular binge eating, laxative use, or vomiting. And participation is I can't think of the word, is supported by a gift card for all participants who complete the study. And I've set out on the right on this slide the various steps of the study for you. And those steps are consent and assent forms for completing the questionnaires, an eligibility questionnaire, a consent or assent for storage of saliva. Saliva we collect to carry out the genomic test. And we then ask participants to provide names and email and mailing address. And we then ask participants to complete the remaining questionnaires using a link that is sent by email. And we then send a kit home that can be used for collecting saliva, and that will then be mailed to us. And I wanted to really highlight here that the study can be fully completed at home. And we think that that's quite important, because we know that often families who have a child with ARFID, for example, have a lot of burden, and it might be quite hard to come to a clinic and do a lengthy assessment. So this is very important that the assessment can be completed fully at home. We are studying quite a lot of domains in relation to ARFID, and we feel this is quite important based on what Lisa and I have told you up to now, which is that really there are a variety of co-occurring issues, and also possible predictive or predictor, so that might be relevant to the development of ARFID. So we think it is important that we really assess a range of domains, and those go from neurodiversity to co-occurrent medical and psychological symptoms. Of course, a good assessment of ARFID symptoms and history, a good battery of assessments of other psychiatric or psychological symptoms, but also an important question for us was quality of life. We know very, very little about quality of life of individuals with ARFID. And of course, some questions about environmental factors or things that might have happened to the individual or the child prior to the development of ARFID. And of course, we have made sure that there is an age-appropriate version of all questionnaires. And as I was saying, we ask parents to answer some questions about the child when it is not appropriate to ask the child, and vice versa. We ask the individual to report on their own experiences and symptoms if the age is appropriate. We know that there are some challenges in carrying out this study, and we know that it might be particularly taxing to reach parents of children who are living with ARFID. And we have explored various avenues to do so, but we know that it might be a challenge, especially for a disorder that it's not always appropriately diagnosed. And because of that, we really want to reach families who might be unaware that their child has a treatable disorder and a disorder that has a name. And that, of course, is an important challenge that we need to think about. Another important aspect is ensuring that participation in the study is across all backgrounds, and that is backgrounds in terms of socioeconomic status, gender, race, ethnicity, etc., etc. We really care about this study having representations across all those domains. And of course, we know that there might be some hesitancy about the genetic portion of the study. As you saw in the community feedback, some parents or individuals with lived experience, brought this up as something that, might be kind of slightly worrying for some participants. Lastly, I want to kind of point you towards our resources. On the right, you see our Instagram and Twitter and Facebook accounts, and we have all of those, and you can see here what our Facebook handle is and our website, ARFID-GEN.org. Of course, Lisa and I, could not finish without highlighting that this is really a team effort, and all these colleagues listed on the slide are working very hard on this study to try and make it happen. And just a quick preview from Lisa.
Yes, exactly. So we're starting a sister study now in Sweden that is called AREAS, ARFID Initiative Sweden, and will be very similar to ARFID-GEN. And we're really hoping to extend this effort to other countries later on as well. So I think this will be a worldwide study, as also our previous genomic studies have been, for example, the Eating Disorder Genetics Initiative, F.E.A.S.T.
Great, and we want to finish by sharing some take-home messages before we open the floor to any questions or comments. So first, highlighting that ARFID is a common disorder and that it is as common, if not more common, than anorexia nervosa. I really see my role, and I know Lisa shares this, as an ambassador for ARFID and an ambassador for those of you with lived experience or with loved ones with ARFID who don't have a voice and who need to be aware of this and need to bring this awareness. We know that clinical presentations of ARFID are very heterogeneous, and as we know more about ARFID, we are discovering more about what the different clinical presentations are and how they overlap, and the fact that they might not necessarily be mutually exclusive. We know relatively little about the etiology of ARFID and why ARFID develops, what the risk factors are, but we are starting to understand more. And this study that I just shared with you, ARFID-GEN, is one of the efforts that are starting to get us to understand more about why ARFID develops. We know that genomic research of ARFID is lagging behind that of other eating disorders, and we think that it has a great potential because this type of research has really, really changed how we see anorexia nervosa. And we've seen many, many studies starting and trying to understand anorexia nervosa more from a different perspective, thanks to all that work that was done in genomics. And we really, really believe that if we understand why ARFID develops, then we can help improve identification, diagnosis, and treatment for everyone. And with that, we would like to thank you and then open the floor for any questions. And I know that some of you will be looking at these slides and watching this webinar later in their own time. And I would urge you, if you have any questions, don't hesitate to drop us an email or get in touch. We are always happy to answer any questions.
Thank you very much for a really interesting presentation. I actually have a few questions. If anyone else has questions, please put them in the chat box, but I'll get us started. You mentioned parent coaching. as part of treatment. And I was wondering what type of things would be included in parent coaching? And more broadly, how do parents support a loved one with ARFID? I'm very familiar with anorexia, how you do that. But with ARFID, I'm really unclear on what the parent role is and how the parent works with the treatment team and what this parent coaching is.
That's a very big question. Nadia, do you want to start or should I?
I'm happy to start if you want, Lisa.
Yeah.
So I think that is a great question, Judy, and certainly, one that I think is important to highlight. Certainly, in all treatment of children and adolescents with ARFID, we would see the parent as an important part of the treatment, an important support to the treatment. And that is kind of due to two reasons. One, because of course, as in all eating disorder type treatments, part of the work that is done in the treatment room is only limited, and a lot of the treatment, particularly in relation to behavioral strategies that are used in treatment, is also carried on and done at home. And we often, talk to parents about how in the treatment room, we kind of coach them and show them how to kind of practice some of the experiments that we do with the child that then can be practiced at home. And that is true of both treatments that are being used with ARFID in terms of the cognitive behavioral, the behavioral, and also the SBT adaptation to ARFID. So the role of the parent can be quite important in the treatment, both in the treatment room, but also at home.
Yeah, and I think then part of the parent coaching, of course, is also a lot of the basics. So basically psychoeducation again, right? Explaining what ARFID is, what in their child leads to the food avoidance, to really understand which presentation it is, and to work on these drivers of food avoidance. And then, it differs very much on the exact presentation. What the strategies are. But for example, it can be simple things like if you do food tasting, if the child doesn't accept any new foods and has a very narrow range, you would recommend to do these food tastings outside of the normal meals, to have this as extra sessions, basically. So to not disturb the meal times so much, and to not have the child associate meal times with something very bad, for example. So things like these will be taught.
It's interesting. I would assume also parents need some type of distress tolerance training, because it must be extremely difficult. You were talking about exposure therapy. And as a parent, it's really hard when your child is deathly scared of eating certain foods, and you have to basically make them. It must be really hard for parents of kids with ARFID. So I imagine that would be very helpful for parents as well, to learn how to tolerate their child's distress as well as their own.
Yeah, that's a really good point, like anxiety management for the parents also, right? And I think it also really helps for the parents to know that the child is in good hands, like nutritionally and medically, So if there's a dietitian and a doctor who say, your child is getting enough on this side, don't worry, So this is one part, but then also I think expectation management is a really big part of parent coaching or treatment, because things can take a very long time to change, especially with children who have this sensory-based avoidance. And also, they might not be the most diverse eaters ever, right? They might have a very limited diet all their life, but then they can live well with this diet. That's the goal, I think. So yeah, setting realistic goals is an important part also.
Okay. And yeah, I mean, just a few comments that someone said that she's been in the family-based treatment program in Philadelphia, and it was geared toward her teen's particular type of ARFID, and the feeding is heavily parent-run at home, which I would expect. That makes perfect sense.
Yeah.
I mean, the child lives at home, so that's where they
Absolutely.
primarily would be done, which is where that parent education and the psychoeducation really, heavily, impacts the parent's ability to do this. And another comment is this type of parent training would be beneficial for parents of kids with all eating disorders. And that's also true. A lot of the mechanics of the feeding are the same, even when the eating disorders are different. From a parent perspective, a lot of times we need the same skills. So I definitely agree. I have one final question. Again, mine, because I don't see any here, is you talked about comorbidity. And I was curious, how do you know what's the primary diagnosis and what's the comorbid? And does it impact treatment? Meaning, if ARFID is not the primary diagnosis, if ARFID is a comorbidity, does it impact the way you treat the ARFID?
It is a great question, and I get asked this question every time I do a talk on ARFID. I think it is a very important one, and I think it's also that's also why it is important to have a multidisciplinary type approach to ARFID, and one where you're really understanding the different comorbidities. And it's there's also not a one-size-fits-all answer, because I think it is very, very individual, in the sense that it really depends on the comorbidity, on how the other disorder might be kind of affecting ARFID or entangled with ARFID. So it is very, very individual how you do that. And there are cases where, for example, if there is a medical disorder that has a huge impact on the ARFID presentation, then unless you can treat that medical disorder or change some of the kind of physical effects, then you can't really change ARFID. And I've been in a situation as a clinician where sometimes I have had to say that to families or parents, that the medical disorder is such that it is very, very difficult to change ARFID behaviors without doing something for the physical disorder. Other times, you can actually treat the two disorders together. And, for example, when there is an anxiety disorder and there is an ARFID presentation that's very kind of anxiety-based, so concern of aversive consequences, then, when you treat the ARFID, you can actually also treat the anxiety disorder. So to me, as a clinician, it is, very dependent on the context and the individual. But it is important to assess everything and really try and unpick what can be treated and what might affect what. Lisa, I don't know if you have any other suggestions.
Yeah, no, that was very well explained, and maybe also what is more urgent to treat or what is maybe more likely to have a successful treatment. And as you say, it's very individual. So for example, when it comes to ADHD, we usually think that it's very important that the ADHD is managed first in order to have a successful treatment of ARFID, if the problem is really around structure and routines and hyperactivity type things in terms of eating. So, yeah.
Thank you. We're almost out of time, but there's one question I just want to say yes or no. Will your study yield data on the prevalence of overlapping co-occurring conditions like autism or ADHD and ARFID?
Yes, absolutely.
That's a great question. Yes, of course. And that's why, we have decided to go with a large battery that helps us understand these co-occurring disorders, both psychiatric, psychological, and physical. So we think it is very, very important. So yes.
Thank you. So I just want to end, first of all, again, by saying thank you. There were very few people on this webinar, but I know there's going to be so many views afterwards. We actually got an email from a parent just now who said he couldn't make the webinar, but he's desperate for information for his 23-year-old son. So, it's really gratifying to know that even if it's not in real time, you really are helping a lot of parents. And I also want to say thank you for your research. I think as parents, we really appreciate the research that you're doing, because it's really only through this research that we're going to see improvements in treatment. So thank you for that as well. There are very few people here, but I will just say, if you like this webinar, if you have the means, we offer all of our services for free, and we can only do that through the continued support of our community. So if you have a minute and you want to make a little donation to F.E.A.S.T, that would be really great. And for next month, we have another great webinar, which is going to take place on June 21st. And it is on relapse in eating disorders, navigating the challenges and supporting recovery, which is a topic that I think every parent with a child with any eating disorder really can benefit from. So thank you again so much to our presenters. Thank you so much for the people who are here. I know we all learned a lot today, and we really appreciate it. So thank you and goodbye.